This is a 3-year-old girl child who was brought in with central congenital cataracts, and it was decided to take her up under GA as there was significant visual drop. So after placing the incisions and staining the capsule with trypan blue, just expressing out the trypan blue and the air bubble with HPMC, I go ahead and initiate my anterior rhexis with a bent 26 gauge needle initially. Just getting a small flap, and once I have got that, I go ahead and continue the rhexis with my Utrata forceps. Notice how elastic the capsule is. You have to be a little careful. I'm aiming for a 5.5 rhexis. You always try to make a smaller one due to the elasticity of these young capsules. And I am pulling, just watch the movement, I am pulling directly towards the center, towards me, to get that rhexis into shape. And once that is done, rhexis is more than adequate, I go ahead and do my hydrodissection, and the soft nucleus has prolapsed out. There's nothing much, just a gelatinous mass which I aspirate. I am in an aspiration mode. There is no phaco power at all. Go ahead and aspirate all the nucleus and the epinucleus. Then using my bimanual, I go ahead and make sure I completely remove all the cortical material from the bag. It's very easy to do this. Just patiently going around the entire 360 degrees of the bag. I am not changing hands. I don't want to keep on having fluctuations in the AC. So at one go I am going ahead and removing all the cortex. And you can see how easily it comes. That's almost the last bit. Just a bit left. And that's done. I just put in HPMC before I come out with my irrigation, and I have gone in to a higher magnification. Now is the time for doing the posterior capsular rhexis. I have gone into the posterior capsule with my 27 gauge needle, injected a wee bit of visco to lift up the capsule. I am now tenting that the tear. I could not see my tear, and this is because of the bright reflex from the omni-glow as well as the microscope right in the center. And I probably should have made my opening a little larger for me to see and more paracentral. Anyway, I'm sorry, the recording it's not showing too well, especially because of that bright reflex right in front of it. And it was a little bit difficult to focus as well. And I've got the flap and I'm slowly getting my posterior axis. You will better appreciate the posterior axis once I am done. I completely agree, it's not very easy to see, but you can make out the capsule being torn in a circular fashion. I just make use of both my paracentesis wound and the main wound to fashion the posterior axis. And once done, I just put in a wee bit of HPMC and then do a very, very mild vitrectomy through the posterior capsulotomy. This is just to remove the anterior scaffold. And that's it. Once I have done that, I am just inflating the phonesis of the bag. I come down to a lower magnification and I am going to inject my single piece foldable IOL within the leaflets of that bag. And here I have put in the leading haptic under the anterior capsular axis and over the posterior axis. The trailing haptic is still in the anterior chamber. I am going to put it into place with the help of dialers. And I take 2 Sinskey hooks, actually 1, and I slowly tuck it into place. You can see it beautifully going into place, just centering the lens. And now you can appreciate the posterior axis very well there. That's the posterior axis. The middle part is the breach in the anterior hyaloid face and my small vitrectomy. And then under very low flow, a controlled flow rather, I will be taking out all the HPMC from the chamber. There is some bit of cortex of the cornea. You can leave it or you can take it out. I prefer to take it out and very gently tapping on the lens to get out all the HPMC from behind. Putting in my marks, sealing my wounds and checking the integrity of the globe. Thank you very much for watching.